start today, and the first cab off the rank is Dr. Yasmin Hurd. She is a professor of psychiatry, neuroscience and pharmacological sciences, as well as the Ward Coleman Chair of Translational Neuroscience at the Icahn School of Medicine in New York. She is highly published, and in addition to her research, she is the director for the Centre of Addictive Disorders within the Mount Sinai Behavioural Health System, which covers one of the largest addiction populations in the USA. Today, she discusses the significant focus of her research, which investigates and evaluates the therapeutic potential of novel medications such as the use of specific phytocannabinoids in the treatment of psychiatric disorders, including opioid abuse, very relevant to what I'll be speaking about later in the afternoon. Her title is Cannabis as a Viable Therapy for Opioid Addiction. Please give her a warm CannaTech welcome. Please, as the first speaker of this morning. Pleasure.
This is really surreal, actually. What an event. Yesterday was an amazing time for me because I'd never been to a non-scientific, really deep science, or especially neuroscience conference, and I learned so much. And the thing that you said, I think that we're all here because we care. And I'm going to bring you down a path. Well, first I have to get my slide projector. Yeah. So I'm going to bring you down a path that got me into changing my mind about some aspects of marijuana. Because most of my research until a few years ago, really I didn't see that the need for legalization. And then as you started doing research, you realize that there's much more questions out there that we thought that we knew and that we really don't. And research really got me to start changing my mind. So today I'm going to talk to you a little bit about the miracle drug. You know, we have a miracle drug, but the miracle drug is actually this poppy opium. I think I just want to walk you down a history very quickly because this was considered the miracle drug from like 5,000, like 3,000 to 5,000 years ago. The Sumerians in Mesopotamia, where we're close by right now, which is great in a way, the joy plant was considered, you know, an aspect of treating pain. They saw this that made them feel good. Many cultures started using it around 200 AD or so. Even it's noted that this very famous Chinese surgeon started putting even cannabis indica in opium. And I want to come back to that later, because before surgery, which is really interesting. But fast forward, you started getting that the alchemists then introduced it in pills. We then had German chemists isolated morphine for the first time. Then in around the 19th century, it's really became very widespread use in the US for pain. And I always love this, women's ailments. Well, actually, for women's ailments, it's been for a while. And then a huge thing happened in about 1898, heroin, because they were able to make this out of this morphine substitute. And at the same time, the syringe was made for that, which is also an aspect that brought us down there. And all throughout this history, even the Civil War in the US, the soldiers has been, in a way, our guinea pigs, because the soldiers started showing this addiction, and they called it the soldier's disease. And by 1914 in the US, then they started making these acts to make them illegal. In 1916, again, the German chemist, oxycodone was formed. And in the 1997s, Purdue Pharma, really, there was a lot of aggressive pharmaceutical marketing that this could save and cure everybody for pain. So we've gone down this path, and where we are today is this. We have we have flooded the planet with opioid prescriptions. We have flooded the planet with heroin from many, many countries, so that these numbers aren't the latest, but this is now the fastest growing epidemic. It's a pandemic. of opioid abuse. In the US, we have, for every one death, there are all of these issues that we have, and these are actually low numbers. So you have like 32 emergency visits for every one death, 130 people who are dependent. It's crazy. The heroin overdose since 2004 in the US has increased over 70%. For 4 out of every 5 new heroin abuser started with opioid prescription. We have more people, about the same number of people being prescribed opioid every day that is the population of the United States. We have the healthcare costs, actually this number is incorrect in the sense of this is around 80 billion. We have trillions that this is used. And the opioid abusers cost our societies a lot more. Until about a year ago, I mean, now every day about 80 people die each day in the US. About a year ago, it was about 125 or so, till legislation changed, and police and our patients, we give them Narcan, the opioid antagonist, and you've saved so many people from overdose. But still, you have, like I said, over 80 people in the US dying every day. This is more than car accidents, and in our very violent society, more than gun violence. Shocking. This is one of the problems that we must deal with. This is just showing the actual numbers in terms of just showing the increase in overdose in both prescription and heroin use over the past decade or so. The thing that I wanted to emphasize is that this epidemic is actually not new. We've had an opioid epidemic before in the US. I should have checked other parts of the world, but this is a 33-year follow-up of what happened in one of those epidemics. So when people came back from the Vietnam War and there were a number of people dependent on heroin, this is what happened. Nearly 50% of them were dead. We had many people started off being incarcerated. I guess they died by the time, and only about 20% were abstinent at 30-year follow-up. So are we on track for the same thing? And as I showed you the overdose deaths, we're close to that. This is what we do for opioid addiction today. We give opioid targeted treatments. We give methadone, we give buprenorphine, and we also give the opioid antagonist, naltrexone. So everything is targeted to the opioid system, to our endogenous opioid system, when we develop treatments. We also try behavioral therapies, of course, and those definitely are needed. I had just put this here to remind people of, again, the cost. So this is a $1 trillion business that we've now created with all of the opioid abusers out there. $1 trillion business. So what are we going to do? We have people in serious pain that lead to the addictions. We have been prescribing a set of these opioids. So a number of years ago, this whole thing of marijuana. So can marijuana really be an alternative treatment? This is the thing that we weigh. We weigh whether or not we continue with our opioid prescriptions, or can marijuana provide some benefits. So one of the things, if you compare them, opioids have definitely a very high abuse potential as compared to marijuana. They have a very high overdose potential as well. I'm just showing you some of the facts of this. Heroin and fentanyl and all of these opioids are the drugs that have the greatest lethality, and some of the, in comparison also with their abuse potential. If you look where marijuana is very low on this list. And this is data from actual research. So again, if we can use data and research out there, we know what the differences are. The overdose potential is because the opioid the opioid receptors that mediate the effects of heroin in terms of the reward and so on are also highly expressed in our brainstem. Here in this cartoon is the blue color. That's our brainstem, the respiratory center, so that deals with why people overdose. The cannabinoid receptors are not highly expressed there, so they're not producing the overdose, and that's basically one of the main reasons. When we look at the opioid, the CNS mechanisms of the opioid system, we actually know a lot about it. Even though cannabis has been around for thousands of years, and yes, there's a lot of research being done, we still don't know really a lot about the mechanism of action and even the entourage effects of all the other components of the plant. And that's something I think that I'm really happy to see so many people are embracing the need for that. We also, so for me, one of the things when you started looking at the data in the states that have legalized marijuana, one of the things started to pop out. One is that there are lower numbers of prescription for opioid painkillers in these states. There are reduced numbers of opioid overdose deaths, and even reduced numbers of positive opioid toxicology in people in the car fatalities. Whether or not this is causative, clearly we don't know, but it was just quite interesting that already we see this reduction in opioid use in these states of legalized marijuana. Just passing by this. So the question for me was, which cannabinoids might be doing this? If it's THC, we know that there are over 140 cannabinoids in the plant, and we went with everything else in the sense of the two most concentrated cannabinoids in the plant. And as a scientist, we wanted to first focus on specific cannabinoids in terms of then all of the plant. So we have THC and we had cannabidiol, and that's what we decided to look at. I just added these slides just to show you, this is the cannabinoid receptor in the human brain. I love it. This is the primary receptor in the brain that mediates the effects of THC predominantly, but it's the most abundant G protein-coupled receptor in our brains. It modulates synaptic communication, and as I said, I think it's really beautiful. We also have our natural endogenous cannabinoid ligands, such as anandamide and 2-AG. But CBD as compared to THC, we know a lot about THC and its mechanism as a partial agonist at the CB1 receptor. But CBD, there's still controversies about its mechanism of action, but we do know that it modulates an endogenous anandamide. It's potentially a negative allosteric modulator at the CB1 receptor and so on. What we had seen early was that THC, we know in all our patients, many people have published that it exacerbates aspects of psychosis. And even that's why people take it, you feel high, you feel good, and it could lead to dependence in some populations. And CBD was showing the opposite. It was actually showing that it inhibited psychosis. So we wondered, for me, I said to my group, what does it do for drug dependence? And so we started looking at this, and in terms of trying to look at medication development, you start for us in the preclinical model and then go to clinical trials. And so this is where we first started. I'm not going to show you everything, but one of the things just to show that where my research had been focused is that whenever we gave THC, especially during adolescence, we always saw that it exacerbated the self-administration of heroin in our animal models. So we know that there's a neurobiological thing, irrespective of your friends or your mom or whatever, that it did change the brain long term. So what about CBD? So we gave cannabidiol to our rats that were self-administering heroin, and actually during that time we didn't see an effect on the self-administration of heroin. It actually had no behavioral effects. A fascinating thing happened though. The next day, you put the animals back into that operant chamber where they control their drug intake behavior, and usually a light will tell them that the drug is coming. And the environmental cues, or even with humans, are the things that trigger the craving. The thing is that the animals stopped self-administering heroin. It was really surprising. And 2 weeks after their cannabidiol exposure, if you showed them the cue light, it didn't trigger this craving relapse behavior that we had seen classically with heroin exposure. We can show with other different stresses, cannabidiol stress that induces heroin-seeking behavior doesn't do that. It blocks it. So what does the human brain, I always said to the people in my group, I don't really care what's happening in a rat brain. What does it mean for humans? And so, unfortunately, as I said, many people die from heroin, and I study their brains. I do molecular biology. And although dopamine, the transmitter that many people know, is important for reward, when you look in the brains of people who are heroin abusers, the glutamatergic system is really impaired. If you look at every gene in our genome, those related to glutamate, and that's important for synaptic plasticity and drug-seeking behavior. Dopamine may mediate the primary reward, but that goes after a while. It's the glutamatergic system that we see impaired. And one of the things that we saw is that cannabidiol, the animals self-administering heroin has said their glutamatergic system is impaired, cannabidiol reverses that. It normalizes the glutamatergic system. It also normalizes the cannabinoid opiates, alter the natural endogenous cannabinoid system, and CBD normalizes that impairment. So at Mount Sinai, I headed a direct a center, which will now be an institute, that we have over 6,000 opioid abusers. We have over 10,000 people with chronic pain every year. And so we start to think differently. We have to change how we think in order to treat this epidemic. We can't keep going down the same opioid line. If we continue to treat with opiates, we're going to end with even more. So started to look at cannabidiol as a potential treatment. At that time, I needed to get GW Pharma on the line, and because I tried many companies to get cannabidiol, and they gave it. And this is what we saw. We tested for craving. I'm going to go past this. We saw that cannabidiol in our human addicts, when you give them heroin Q and they started craving, cannabidiol blocks that. It also blocks the anxiety. And like our rats, a week after they had their last cannabidiol, it still blocked their craving. So whatever cannabidiol is doing, it has a really profound effect on normalizing those transmitter systems. And so for me, it has a very low abuse potential, no side effects. I didn't show you the things of I see you're flashing. It has a long-lasting therapeutic effect, which is important medicinally. And so for me, as I said, we know that cannabidiol shows this promise of a treatment for, I just had put this here, for what are the things that are important for us. Wait. Oh, that was saying that we don't want medical marijuana to be, again, this miracle drug. We need a patient-centered approach, evidence-based medicine. As I showed you, you do research, you provide the data to show specifically how cannabidiol can, in fact, impact our patients. And hopefully the urgency for this epidemic is getting everybody together to be part of our International Clinical Cannabis Research Consortium. And I thank you for listening to how we got here.
Have they got me on? Yeah. A very compelling, provocative argument in regards to a very serious consideration in regards to opioid misuse and, as you said, the pandemic effect that it's having on our current population in regards to opioids and addiction. This is an area that's been going on for way too long, and I think that this type of research just reinforces again to all of us the importance of looking at an alternative. Einstein once said that doing the same thing over and over again and expecting the same result is the definition of insanity. And I tend to agree with that, because we are using the same methods over and over again in a time and a time frame which is basically considered abusive. What we're doing is we're creating these destructive tendencies in the people we're meant to be treating. So what we need to do is reverse it on its axis and look at the problem and provide a solution. And a solution such as using the cannabinoids and using low THC to reduce that euphoric and addictive percentage in this population is going to enable us to hopefully provide a much better alternative where the side effect, the major side effect, is not going to be fatality. And this is what we have to look at. Opioid misuse and ineffective regimes and addiction causes death. Cannabis, medicinal cannabis, does not. So we need to be looking at a much better solution that is going to more effectively meet the need of our people and manage their pain or whatever other type of issue or condition that we're trying to meet.